and we'll get started. Now, a large portion of what I've talked about through all these various talks is not just the history of medicine and the idea that we move from one success to the next, but it's a lot more about the blind alleys and the outright mistakes that we've made. And I saved this lecture to the last, not because I don't think it's important. In fact, I'm finishing with it because I think it's very important, is that amongst the biggest mistakes we've made as human beings is not recognizing the talent and the contributions of huge cross-sections of our society. So today we're going to be focusing on the contributions that have been made by women and other minority groups, but in particular how we've excluded those groups from the main line of Western medical tradition and how it's really been to our detriment. So I'm not up here trying to flagellate myself as a rich white male, but let's face facts. Most of the people I've talked about throughout this entire series have looked an awful lot like me. And whether that's good or bad, we want to make sure that the practice of medicine and science in general is open to as many people as possible as we move further and further into the 21st century. So early on, the earliest evidence we have of women in medicine is not of specific women, but of deities, female deities in the polytheistic societies of Greece, Egypt, Rome, that were associated with various temples and healing practices. And just as healing in general was tied to temples and spiritual activity, so were women healers. So priestesses at various temples would have certain activities they do that involved healing. There are two particular deities, the daughters of Asclepius, Hygeia and Panacea, that we've discussed before, who embodied specific attributes of health. Hygeia being preventative disease, and Panacea being the ailment, the way that you cure ailments, the complete list of medical interventions that deal with health when it's broken down. The first named woman we know of involved in medicine and, in fact, science at all is Merit Ptah. She was the chief physician to the pharaoh way back in about roughly 2500 BC. And she's not only the first named woman doctor, she's the first woman of any name that we know of. So her notoriety as chief physician to the pharaoh was really noted. The fact that she oversaw most of the activities of the pharaoh's court involving healing are noted in several papyri. She's noted as the author of several recipes for various ailments and ways to treat various ailments. Now, as you'd expect, these ailments were not unique to Egypt, but were pretty remarkably located in that area, and the treatments were not what we would consider to be standard of care today. For example, most common contraceptive was crocodile dung, and before you have to imagine it, yes, it was meant to be inserted. So what we would consider to be good medicine these days, not necessarily correlating with ancient practices. But she was roughly contemporary with Imhotep, the Egyptian kind of polymath, brilliant scientist who later became known as one of the Egyptian gods related to healing. So the two of them are roughly contemporary, which is kind of interesting. Now moving forward, we come into ancient Greece. About 300 BC, we've got Agnotocy. She actually practiced as a physician, but had to disguise herself as a man. Greek and Roman society was anything but egalitarian. Women were very strictly regulated in what they were allowed to do and what they were allowed to, where they were allowed to go. So practicing medicine was very difficult. She studied at Alexandria with one of the anatomists there, Herophilus. We've mentioned him in passing. And she practiced secretly, but was eventually discovered and denounced. Before she could be prevented from practicing, though, her female patients rioted and basically prevented any real measures being taken against her, because these women basically said that they would make life miserable for everyone in town if any censure was applied to her. Moving forward, we're going to see that ancient Greece and Rome were relatively patriarchal, but there was at least a role for women as healers in there. There were the temples of the various goddesses that were associated sometimes with healing. But as the various monotheistic cultures that came in to Europe and the Middle East took extreme precedence, not only were there no women gods, there were no multiple gods at all, let alone any associated with healing and temples. So there was really no role, even a symbolic one, for women in health. They were not allowed to be physicians or surgeons. Women were allowed to work as midwives. So midwifery was considered to be something that a woman was suitable and able to do, but you'll see as male midwives, or later obstetricians, became more prominent, more pressure was exerted on the midwives and other practitioners that were around to be pushed out of practice. So this was something that women were allowed to do, but there was always that push to kind of marginalize their efforts whenever male competitors could come in and displace them. So, a couple bright spots. Just as we had Guy de Chalac in Avignon, one of the few medical and surgical practitioners who was able to bring a little bit of enlightenment to the Middle Ages, we've got Hildegard of Bingen. She was a nun, and she actually practiced medicine, wrote voluminously on it, along with several other topics like theology, and she wrote a lot of different things related to classifying disease and treating disease. And as you might expect, because obstetrics, midwifery was something that was practiced by women in her convent at the time, she did do quite a bit of work on the birthing process, obstetrics, and so forth. We'll be right back with the screen in just a second. I've been assured not to panic. So Hildegard of Bingen, very, very influential person in the Middle Ages, and I really have to say, she's just a dead ringer for Maggie Smith. I mean, just come on. And everything to do with Maggie Smith is awesome, therefore, so is Hildegard. All right, so in the Middle Ages, again, women had a very peripheral existence as physicians and healers. They were allowed to work so long as they weren't really seen as competition for the academic physicians. There were women who operated as quote-unquote wise women who would provide medical advice, give general kind of ideas about how someone's health would proceed and what sort of interventions they could do to keep it intact. But as quickly as possible, male competitors tried to push them out of any area where they might actually cut into their own practice. In fact, in 1322, there was a woman named Jacoba Felix who was charged by the Faculty of Medicine at Paris with practicing medicine, and they didn't like the fact that they thought she was poaching on their territory by examining urine. As we talked about, physicians were all about examining urine in the Middle Ages, and I love this, feeling the pulse and touching the bodies and limbs of the sick. I think they were also upset that she was actually touching people rather than just looking at their urine, which is what a good physician was supposed to do back in those days. Now, by the mid-14th century, in the 1300s, women had pretty much been moved out of any sort of practice of medicine aside from midwifery. Now, in one of the really interesting things is that as we moved into the Enlightenment, in 1581, Queen Elizabeth, the famous Queen Elizabeth, was petitioned to allow a woman healer to continue practicing. And who's seen any of the Elizabeth movies? Okay, if you remember Walsingham, he was one of her chief advisors. He actually kind of petitioned on this woman's behalf to Queen Elizabeth. And it's kind of interesting to read the terminology that goes with it. The College of Physicians really didn't like this woman practicing. And essentially they said, oh, she's an excellent healer, but we just can't have her doing it because of the horrible precedent it sets that women are actually being allowed to help other people in a medical sense. So essentially, the Queen even recommended that this woman be allowed to practice, but the College of Physicians still claimed that it was a dangerous precedent and they weren't going to stand for it. So didn't quite win that round, even when the Queen was in the corner of the person involved. So as we moved into the 1800s, one thing I really want to kind of drive home is we've talked about the humoral theory of disease and how this lasted for 1,300 years. This humoral theory was there. And even though there were many people who practiced medicine in various capacities, such as apothecaries who sold the medicines and prepared them, midwives, bone setters, people who would set fractures if they were non-displaced, non-compound. Surgeons, we talked a lot about them doing amputation, as well as barber surgeons taking care of wounds, and physicians. All these people had a place in this specific organization, and they all basically worked under the same paradigm, that it was imbalance of the humors that led to disease. So that error of the humoral theory of disease and the authority of Galen held sway for about 1,300 years. That's pretty horrible, but I'm going to play my best Lawrence from Fishburne meme from The Matrix. What if I told you? There was an even more ridiculous medical medical malady that never existed, yet was present in our lexicon for close to 2,500 years, almost twice the time that we believed in the humoral theory of imbalance. That's a real thing, and that garbage diagnosis, that bucket diagnosis that we just threw on anyone we happen to feel like, was hysteria. So hysteria was well, when you think of hysteria now, what do you think of? Okay, I heard crazy person. Okay, what else? If something's hysterical, does that mean you've gone insane? Funny. Yeah, it's something funny. Hysteria these days tends to have a different meaning in conversation than it did throughout most of history. In most of history, it was a diagnosis of a disordered and erratic mind. And essentially, in ancient Greece, hysteria comes from hysteros. It's the Greek word for uterus. The ancient Greeks believed that when women went through menopause or were otherwise inconvenient to those around them, they went crazy. And it was because their uterus detached and started moving around their body and disrupting the humors and making everything work improperly. And it was felt that that was the root cause. Now, this reason for hysteria didn't really hold any water. And by Roman times, by the 1st century CE, it was pretty much known, okay, the uterus doesn't literally detach, but disorder in the uterus is what leads women to act in these ways that men considered to be hysterical. So from the Middle Ages all the way through the Enlightenment, hysteria was not really linked so much to the uterus, but because it was such a useful bucket diagnosis for people to use, it was linked to lots of different things. And the diagnosis that was quote unquote settled on, even though it was never really settled, was that it involved too much abstinence, or too much sex, or too much thinking about sex, or as it was phrased in some of the literature, erotic fantasies. Reading novels made women hysterical because they were obviously incapable, this is sarcasm, they were obviously incapable of keeping their minds in order and not responding to the stimuli. So hysteria became a very useful diagnosis whenever people, specifically women, were acting in ways that were inconvenient. I should note, men were also diagnosed with hysteria, but it was very uncommon. Hysterical males were clearly in the minority of people who were diagnosed with such maladies. So by the 1800s, it had become more of a neurotic disorder, and Sigmund Freud spent a lot of time working on ways to treat hysteria through talk, what would later become psychoanalysis. Now, eventually, we figured out hysteria was not a real thing. It was this bucket diagnosis that literally any inconvenient act or rebellion or actual mental disturbance could be lumped into. And we came to this realization in, ready for it, 1980. Yay! So way to go, humanity. That's it. I was 7 years old. I was alive when we finally decided hysteria wasn't a real thing. So, hooray. Now, lest you think hysteria was the only way that women were treated differently than men, when you have something as kind of oppressive as a patriarchal society really pushing women down, any justification that can be made will be made to do that. And one thing I really want to hopefully drive home with this is not that men should feel awful and be guilty all the time, but it's that these sort of societal pressures will use any leverage they can get to reassert themselves. So, as new scientific discoveries and new medical paradigms were taking precedence, they were used to justify why women shouldn't be allowed to practice medicine or science. For example, in the 1700s, when the humoral theory was still going strong, it was basically thought, well, women's brains don't have the same fiery, dry, humoral capacity that male brains do. They're too cold and wet to handle the demands of medical education and so forth. Okay, we jettisoned the humoral theory of disease, but guess what? Okay, well, we know the brain's involved, and the lumps on the skull tell us a lot about the underlying brain. Women's brains and skulls, therefore, are obviously shaped in such a way that won't allow them the capacity to, I'm being sarcastic again, I feel like I have to stress that since you can't see my face and the expressions I'm making as I say these horrible words. But essentially, we take any justification we can and use it to justify the existing social order. In the 1900s, we had physiology. So guess what? Mental exercise or even physical exercise was thought to shrivel the ovaries. And oh no, that would just be the worst thing ever. So the fact that women had a unique physiology was then used as a justification to not allow them equal participation in medicine, along with other aspects of life. All right, so women may not have been necessarily barred from practicing medicine, but they were barred from university attendance. And guess what? If you can't attend medical school, you can't practice medicine. So women were de facto barred from medical practice through exclusion into the universities. And even after women were allowed to obtain medical degrees, it was very difficult to set up an independent practice. Hospitals wouldn't necessarily grant them practice rights. They would sometimes have to have a male colleague. And one interesting little echo of this is, have you guys heard recently that female-driven tech companies have started inventing non-existent male CEOs, and that non-existent male CEO will be who all the official correspondence comes from? Have you guys heard about that? Yeah. So it's literally happening, so that to get taken seriously, women in tech have to do what women in medicine were doing 100 years ago, trying to invent a male colleague or have kind of a token male colleague to actually be taken seriously. So don't think that these historical events do not have current echoes. So, one quick thing to boost our sensation here, since I've been nothing but a downer most of this talk, is that A.T. Still opened up the Kirksville School 1 year before Johns Hopkins opened, so beat Johns Hopkins to the mark by 1 year. But A.T. Still's school also allowed women and minorities in on the same basis as white males. So, hooray osteopathy. Harvard and Yale didn't not desegregate, that took even longer, but they didn't allow women in until the late 40s. So we've got decades of not just subtle sexism, but literal, on the books rules against allowing women into various locations to train. So let's talk about a few of the luminaries that were able to operate and make progress in the process that in this entire kind of milieu that we had available. So first off, you may have heard of Elizabeth Blackwell. First woman doctor to graduate from an accredited medical school, graduated from Geneva Medical School in New York, and founded an infirmary for women. This is a kind of a sequence we're going to see a lot, that women and later black doctors have to found hospitals specifically to treat women and black patients because they were not allowed to practice at the existing medical schools and medical hospitals that were present. So she founded an infirmary for women, organized nurses in preparation for the Civil War, and essentially went even further than the infirmary, opened up a women's medical college. And this college had high standards, same sort of entrance exams, same sort of examinations, and accreditation process that other medical schools had to have. And that was necessary to try to get to equal treatment, or at least even commensurate treatment with the other existing schools. Now, small point of pride, the US beat the UK by a few years because it was a few years later that we had the first woman doctor in England, Elizabeth Garrett. And she came through training as an apothecary and then medical school in France. She actually had to leave the country to go to France. France was relatively enlightened, had a lot more relaxed restrictions on who was allowed to attend medical school, and then went back to England to practice and established, as you'd expect, a society for medical women practitioners, as well as a school of medicine specifically for women. Now, you may not even know that Montessori was a person. Who's heard of Montessori schools? Who's heard of Maria Montessori as a separate person? Got a few. But Maria Montessori was a physician trained in Italy, and she was working with disabled children and people who were thought to be relatively hopeless and incapable of independent life outside of a lot of assistance from others. She was working with these students and figured out that they were actually capable of doing a lot more than people expected if they were educated and schooled in very practical ways. And she expanded beyond the treatment of disabled people to children in general and came up with the entire concept of these Montessori schools that are based around creative and kind of engaged educational play, where it's not that it's a chore to go to school and learn stuff, you actually make it into a bit of a game. So Maria Montessori was actually a physician, and the schools that bear her name are directly derived from her teaching. Now, Maud Abbott, I brought up very tangentially in the last talk. She's a physician who was working at McGill College in Canada, and she became the world's leading expert on pediatric cardiology and cardiac malformations. She had a massive collection of heart defects and hearts that were in jars, and became very familiar with how these defects came to be and what the problems were. And it was her and her work came up with an atlas of congenital cardiac diseases that allowed Helen Taussig to actually theorize that they could repair certain defects and flow problems through the heart. And Helen Taussig, I brought up in the last talk on history of surgery. She was a pediatric cardiologist who had been encouraged to not go into medicine but go into public health, because that was perceived to be more womanly to go into public health. But she went to Hopkins, got a job on the pediatric cardiology unit, and you better believe that there were a lot of cracks made about how women are just in love with the hearts of these little children. But she didn't like the fact that her job was basically ameliorating these children's symptoms until they died. She wanted to try to come up with some intervention that could actually help. And she came up with the idea that you could build a ductus arteriosus artificially to get around some of the severe cyanosis associated with tetralogy of Fallot, especially when the tetralogy got very severe. So along with Vivian Thomas and Alfred Blalock, they came up with a surgical intervention that allowed a bypass to be created, and that procedure saved many, many children's lives. And it only stopped being used when the heart-lung bypass machine was created and people were actually able to go in and do repairs on the heart. So instead of having it beating, they were able to actually take the heart offline temporarily, directly repair the defect, and then put it back in. Now, one thing I didn't mention is that she also prevented a major medical outbreak in the United States. Who's heard of thalidomide? What does thalidomide do if a pregnant woman takes it early on in pregnancy? Causes bad limb defects. Thalidomide was an anti-nausea medication, and do pregnant women tend to get nauseated? Yeah, and they tend to get nauseated at about the same time. They get nausea is associated with the same time that limbs are forming. And thalidomide is an extremely potent teratogen. It stops limb formation from happening, causes phocomelia, myromelia, other problems, and it was very pronounced in Europe where thalidomide was marketed. Helen Taussig and Francis Kelly, who became one of the chiefs at the FDA thereafter, really campaigned to prevent thalidomide from being sold in the United States and prevented a lot of these children being born with limb defects. So because I'm not going to look where she's standing because I don't want everybody to call her out, but because Dr. Schmidt's here, I feel obligated to re-mention something I talked about last time, which is Helen Taussig was also deaf, and she worked with the children under her care and took care and assessed their murmurs, their valvular defects, not by listening through a stethoscope, but by palpating their chest wall and feeling for the various thrills and murmurs and things that were present. So she was very, very interested in the tactile aspect of assessing patients. All right, so specific osteopathic medical history, we want to kind of talk about that. Because women were allowed into osteopathic medical training from a very early start, there were several early prominent women in osteopathic medicine. There were 4 women in the first graduating class. Here's the picture. And by 1908, approximately 35% of DOs in the country were women. And by 1923, 50%. What's really interesting is that those numbers have actually dropped over time. Now granted, getting to about 50-50 is a big accomplishment, so a little variation around that mean is to be expected, but they have actually dropped a little bit since then. The Osteopathic Medical Association had women members from its initiation, whereas the AMA didn't take women members until 1915. And the first vice president of the AOA was a woman. Now what's interesting is the first vice president of the AOA was a woman, but we didn't get the first female president of the AOA until 2009. So just because things are better doesn't always mean they're exactly equal. So it has to be something that you can never really sit back and say, oh, we're good, we're equal. Quick aside, I grew up in Wyoming, and anybody here know what Wyoming's little state motto is? What's that? Man, thumbs up for you, the equality state. So it was a big point of pride for us in Wyoming that we were the equality state. We're the first state to allow women to vote alongside men. How enlightened, how awesome. Turns out there weren't enough men in Wyoming to qualify as a state at the time. So women were grudgingly allowed the vote because it would allow Wyoming to become a state. So again, good outcome for possibly not the most noble of reasons. It's the second most embarrassing thing that I've got personally associated with me. I'll tell you the first if we have time later. So essentially, we've got 4 women graduates and some very prominent osteopaths who are women from the very early start in the AOA. Let's talk about a few. We got Nettie Bowles, and she was involved in near osteopathy her entire life. And I feel kind of like a schmuck standing up here while Dr. Schmidt is in the room, so if you want more details, I'm sure she can go into extreme detail on this. If I'm throwing you under the bus, Dr. Schmidt, just throw rotten tomatoes or something at me. But essentially, she was the first editor and publisher of the Journal of the American Osteopathic Association, and the early editors of this journal were almost all women. For a very prolonged time, women were the editors of the JAOA. She practiced, became first woman to be nominated for presidency of the AOA, but as we saw, it took another 90 years for that to actually come to pass. And next up, Louisa Burns. Now I've skipped up, there are many other women involved in early osteopathy. I had to cut some names, and I'm very apologetic about that. However, Louisa Burns is a name everybody here should know because she was a very, very strong proponent of not just osteopathic treatment, but research and how you can get a scientific basis for the efficacy of these treatments. When we talk about viscerosomatic reflexes and their effect on organs and the body, and vice versa from the body to the organs, it was her work that really brought a lot of that into the osteopathic educational realm, the research realm, and a lot of those effects have only really begun to be explored in how the organs and the body interact through the parasympathetic and sympathetic nervous system. So her research and her founding of the Osteopathic Research Institute is very instrumental in gaining a more equal footing with the AMA as osteopaths became more and more prominent in the medical scene. All right, so here, I don't expect you guys to read this, but going from about the 1960s up to roughly now, we're moving from about 7% of medical graduates being women to the high point, 49.3 in the 2007-2008 period, and we've dropped a little bit down to 46% since then, but roughly getting close to 50%. Now, if anybody wants to draw attention to the fact that women actually make up a slight majority of the world population, yeah, you're right, and we're not at 100% equality there. But it's reassuring in a way to know that this movement has occurred over the period of about 50 years. Now, I also want to point out this is data drawn from the AMA because it's a much larger data set, but I will have some specific numbers related to osteopathy near the end of the presentation. Let's shift gears now and see how similar but not identical processes were involved in African American physicians, not just gaining the right to practice and the ability to practice, but the ability to attend medical school on as equal a footing as possible with other candidates. So in the 1900s, after the Civil War, there were roughly 10 medical schools that allowed Black or African American students to attend. And we've talked already about the Flexner Report. In 1910, the Flexner Report suggested massive reforms to improve medical education in the United States, and it did. It set a higher standard, said that everybody needed to follow the Hopkins model. And that's a good thing in that it's raising the standard of medical education from terrible to okay. But some of the bad things that occurred because of the Flexner Report were that the Hopkins model and MD medicine became the massively most influential voice in medicine and medical education. And osteopathic medical schools took a big hit after the Flexner Report, even though they had a very stout curriculum, good academics, good laboratory experiences. There were fewer osteopathic schools left after the Flexner Report. But Black medical schools were hit even harder. The Flexner Report was outright hostile to Black medical schools, suggesting that African American students should go into public health because medicine wasn't really appropriate for African Americans, according to the report. Now again, I'm saying these words, if you can see my face, I honestly I don't believe a word of this, but I have to spout what was said in the Flexner Report to justify that. So by the time 10 years had passed after Flexner, there were only 2 colleges left that accepted African American students. That was going to be the Meharry, which is pictured here, and Howard University Medical Schools. Now, over time, desegregation proceeded. Even schools that weren't segregated in the northern U.S. still were very, very patchy about how readily and how equally they accepted Black medical students. And as desegregation in the South became a little more widespread, some other venues opened, but you can't claim that it was exactly hospitable or equal. And hence the presence of these historically Black medical schools was very important so that there was a venue for these students to actually get an education. In the later part of the 20th century, we had 2 new, primarily African American medical schools open in LA. It's the Charles Drew University, and in Atlanta at the Morehouse School of Medicine. So let's talk about a few luminaries involved here as well. James McCune Smith, I hadn't actually heard about until I was prepping for this presentation. It's really a shame because he's a really interesting person. At age 25, he did what most medical students had to do to get a good medical education, which is leave the US. But he not only had to leave the US to get a good caliber medical education, he had to leave the US because he was not allowed to participate in any programs that existed here. So he went to Glasgow, graduated top of his class, came back, and began practicing in Manhattan. And he was extremely influential, and he became very good friends with Frederick Douglass. The 2 of them worked extensively, writing essays, working to make sure that African Americans were not only able to participate in just life in general in New York, but also in medical life. And they both were instrumental in setting up the Underground Railroad to help freed slaves or escaped slaves make it further north, away from places where the Fugitive Slave Act would have forced them to be forced back into the South. He was excluded from most medical societies that were present at the time, including the AMA. And what's really tragic is shortly after his death, he was really kind of forgotten. He was a really influential person who practiced for a long time, was very, very involved in not quite the Harlem Renaissance, but that early New York-centric kind of flowering of Black culture. And his descendants kind of stopped associating themselves with him. And it's a really weird thing I was trying to read through, but the consistent story is that they distanced themselves from him because he was Black. And they married white spouses, and his descendants, when contacted about him, not only didn't know they were related to him, they didn't know they had a Black ancestor at all. So it was a really weird societal thing where not only was he kind of abandoned by his relations because he was Black, it was even though he was this incredibly influential physician. So it's just a really strange situation. Next up, we got Daniel Hale Williams. Now, he is really notable as an early American surgeon, but also as the person to first publish an intrathoracic surgery. Now, there's some controversy about this, that someone else may have done a very similar operation, but Williams did it independently and was the first one to publicize and publish it. Essentially, he was working in Chicago at a hospital that he had to found to treat black patients in Chicago because the hospitals were segregated. And a young man came in who'd been stabbed, and he had a laceration of the heart. And a thoracic injury at that time was considered to be a death sentence. You don't open the thorax because nothing good will happen, the patient will die, you're a fool for even trying. That was the prevailing theory at the time. But as the patient went into shock, he felt he had to try something. He knew he was going to die if nothing happened, so he might as well try something. He went in through the intercostal space and found that the heart had not been traumatized badly, but there was bleeding from the pericardium. And he was able to suture it up, and he was aware of Listerian technique, so he used antiseptic methods, and several weeks later, this young man who'd been stabbed walked out of the hospital alive and well. So this was the first documented thoracic surgery that was ever done. And he taught at the Meharry College as well, trying to make sure that there was not just good medical education available, but good surgical instruction available to the students at the college, and co-founded the National Medical Association, which accepted black physicians while the AMA did not. Oh, let's see who's next. TikTok, okay. Now, next up, the first African-American woman to graduate from medical school is Rebecca Lee Crumpler. And she graduated from a medical school in the United States, the New England Female Medical College. It was later kind of included in, or brought into Boston Medical College. But she worked very hard in Boston to improve treatment of black patients, make sure that they had a venue for treatment where they weren't excluded from other segregated hospitals. And after the Civil War, she felt very strongly that it was important to go to Virginia and try to set up clinics and medical access for the newly freed African-American citizens of Virginia. Now, she eventually went back to Boston. She was down there for as long as she could, but she endured just horrific racism, not just from the public in general, but from her colleagues, the other physicians who didn't like that she was a woman, didn't like that she was black, and would undercut her at every opportunity and try to make it difficult for her to practice, to admit patients to hospitals, and so forth. So she fought the good fight in Virginia for a while, but eventually went back to Boston, continued practicing, and wrote the first medical textbook by an African-American woman, a book of medical discourses focusing on women's and children's health for use in a lay audience. So it wasn't a textbook for specialists, it was a work of public popular medical advice. All right, so more charts. We can see we've got in orange applicants, gray matriculants, and in purple graduates. African American graduates make up about a little less than 6% of the 2015, I think it's 2015 medical graduates from MD schools. Again, I pulled this not because I think MD schools are better. I teach here, I like teaching here, but because there's just more numbers to draw from to get a sense of what that snapshot is. Very close to the Hispanic and Latino matriculants, applicants, and eventual graduates of medical school. As we look at the actual practicing physicians, no big shock. There's a lot of white physicians practicing. Next, Asian physicians, then Hispanic and black practicing physicians. Now, the medical practitioner snapshot will always be a little bit different than the medical school snapshot. And we'll take a look at that in just a second as well. So here we have the actual osteopathic medical school and graduate snapshot. This is a great chart, but it needs a little breaking down. So on the left, we've got 2009 to 10. Over here, 2016, 17. And we can see that first year enrollment, we've got roughly 45% of enrolled students being female. That's actually down a bit from where we'd expect relative to the AMA data. as well as what we'd expect in a strictly egalitarian society where it's 50-50. So a little bit of work to be done, but we're in that range of statistical variation that's at least implying a little bit of uniformity. And here we can see that non-white or minority status applicants are making up roughly 9% of the first-year medical school poll. Now that's obviously going to be very misleading if we don't look at how that data breaks down according to different groups and different sets of minority students. But just be aware, the data is out there, but it takes deliberate effort to make sure that the admissions process, the outreach to various other schools, is really bringing in as broad a representative student body as possible. All right, so my parting thoughts for everybody at the end of this entire series of talks is that there are a lot of missed opportunities in the history of medicine. Obviously, excluding more than half of the potential people who could contribute is right at the top of that list. Whenever you do not allow people to exercise their talents for reasons that have no basis other than societal prejudice, you're losing out on a huge talent pool. But other things that are more specific are really interesting to follow up with. So we started with Hippocrates on the island of Kos, who came up with the idea of the humoral theory of imbalance. But nearby, on the island of, I think it's pronounced Cnidus, there's another medical tradition that died out. But that medical tradition was eerily similar to our current understanding of how disease works. Instead of looking at people's symptoms and ascribing it to humoral problems, they looked at the regions affected by various symptoms and tried to classify it in what was a proto-pathology. So it was really interesting that they hit on a very modern idea back then, but the context of the time didn't allow them to do anything with it. Chinese and Arabic medical scholars had described the circulation of the blood long before Harvey, but Harvey was the first person to describe it where it got transmitted and really fell into that received wisdom that was maintained. These contributions were only discovered far later, but priority alone doesn't necessarily mean that it'll have the lasting influence it should. For example, Hua Tao, a Chinese physician in the 1st century, was actually reputed to have used anesthetic. Now, we don't have any information on what that means. Was it opium? Was it something else? But anesthetic was not completely unknown in ancient times, but it was never systematically used during surgery or other treatments. And decades before we had any sort of an antiseptic activity going on, where Semmelweis told us to wash our hands, Lister came up with phenol and carbolic acid to disinfect surgical wounds and surgical procedures, there were several physicians who said that they thought germs or something akin to germs were being spread from the physicians to the patients. And a well-known American doctor and anatomist, Oliver Wendell Holmes, said that he thought that hand washing would improve the health and the rates of infection at hospitals. Now that one's particularly galling because it's not just that he said that and people ignored him. He was a celebrity and he just stopped talking about it. And we had like 20, 30 years of people dying unnecessarily where this guy had a massive platform. He was read, he had a column in every newspaper in the country, and people read his column daily. So he had a massively influential platform which he could have promoted hand washing and sanitation in. So it's just bizarre that that never happened. So what makes the difference in medical discoveries and medical innovations that succeed versus the ones that don't? Honestly, it comes down to how well people communicate. And when you talk about medical communication, it's not just with your patients, it's with everybody, it's society in general, because good ideas are not enough. Semmelweis had the right idea to have people wash their hands, but he was a poor communicator. Louis Pasteur was an excellent showman, and that's why we know Pasteur, and his results were promulgated widely. People followed up on it, and he was able to really effectively make his case. There's a quote from a medical history book I particularly like, and it is that great ideas and great inventions do not necessarily win acceptance because of their inherent value. It's not enough to be right. You have to be right and really be persistent. And that is as close to to an inspirational speech as I am likely to ever give, and we will end it right there. Thank you very much.